Astro. And to start this meet, my name is Mariko Kawamura from Nagoya University, and I'll be moderating this webinar. So to start this meeting, I would like to ask Professor Nagata from Hiroshima University, who's the chairman of the JASTRO's International Committee and also council member of FARO, to give welcome remarks. So Dr. Nagata, please.
Hi, good afternoon or good evening, everyone. On behalf of the organizers from JASTRO, I wish to welcome all of you to the 9th FARO webinar of pediatric proton therapy and fertility preservation. My name is Yasushi Nagata. I'm a chairman of the International Committee of JASTRO. Proton therapy is one advanced technology. As of 2020, 98 proton machines are in use, and 31 are under construction, and 29 are under planning in the world. In Japan, 18 in use, and 2 under construction. In Asia, out of Japan, 8 in use, and 17 under construction. In Japan, in a year of 2018, around 6,000 patients were treated with proton. It is about 2.5% of the patients treated with radiotherapy. Of the 6,000 patients, 3,000, around 50%, were reimbursed from national health insurance and the others from private insurance. Prostate cancer, liver cancer, lung cancer, and head and neck cancer are popular. Japanese national health insurance covered localized prostate cancer, pediatric cancer, non-squamous head and neck cancer, and inoperable bone and soft tissue sarcoma for proton therapy. Pediatric cancer is especially a good indication for proton therapy to avoid complications and secondary cancers. To avoid irradiation for fertility preservation, proton therapy is also very useful. Today, I'm very happy to hear 2 topics by Dr. Uezono and Dr. Kawamura and the following discussion. Anyhow, proton is a very promising technology. I hope a fruit discussion through this meeting. After COVID-19, I'm looking forward to seeing you again. Thank you very much for your attention. Thank you.
Thank you. Thank you, Dr. Nagata. Our valued sponsor, supporter, Varian, will introduce us Dr. Smith. Unfortunately, he couldn't join us in live, so his lecture will be a pre-recorded one. And so, Vishal, if you're ready, please, can you start the record?
Thank you. Yes, I can start. Am I audible? Yeah. Thank you, Mariko-san, and thank you, FARO members, for giving Varian this opportunity. So I'll just share the video by Dr. Ed Smith from Christie Hospital, Manchester, UK, on pediatrics, proton therapy applications in pediatrics.
I would like to thank the organizer. For this opportunity to
somehow it's not running
at the Christie Hospital in Manchester.
It's not
I'm
running.
Dr. Ed Smith, Clinical Director of the Proton Centre here.
Yeah, we cannot see the screen.
Just give me a second. I'll try to run it again. Are you able to see my screen?
Not now.
Not yet.
Yeah, we can see.
I would like to thank the organisers for this opportunity to talk about paediatric proton therapy at the Christie Hospital in Manchester. I'm Dr. Ed Smith, Clinical Director of the Proton Centre here and lead paediatric radiation oncologist. And in this picture you can see our Proton Centre mascot, the Proton Panda. Here are my disclosures. As you can see, I'm being supported by Varian to make this presentation, and I have no other conflicts of interest to report. So, proton therapy for UK patients is not new. There's been a Proton Overseas programme for 13 years, where the UK sent patients abroad to Europe and the United States. The Christie opened its service in 2018, and given the COVID pandemic, has been the sole provider of NHS proton therapy to UK and some Irish patients. In October, we welcomed the opening of another NHS facility at UCLH in London. The routinely commissioned indications that we treat are generally accepted indications internationally. It's important to bear in mind that both the Christie and UCH will operate with over 50% of our patients being treated on clinical trials when we're at full capacity, and all patients are enrolled on a surveillance study, which I'll come back to. The UK programme has treated over 2,200 patients to date. The great majority of these have been paediatric, although a significant number of teenagers, young adults and adults. The opening of the Proton Centre in Manchester also saw the first proton trial that we opened in the UK, and that's a trial called Torpedo in adult oropharyngeal cancer. The Christie Proton Therapy Centre is co-located with the main Christie Hospital, which is a specialist cancer centre in the northwest of England. As such, it's co-located with chemotherapy services, radiotherapy, including MR-Linac and brachytherapy, young oncology, acute oncology, and as you would expect, the full suite of radiology and histopathological and hematology and biochemistry support, as well as a critical care unit. The centre itself is above ground and is light and spacious and spans over 4 floors. We're a Varian facility. Our cyclotron is named Emmeline, after Emmeline Pankhurst, who was a famous suffragette from the early 20th century and who was originally from the Manchester area where the hospital is sited. We run 3 full 360-degree gantries to provide service, which was important to us given the complex nature of our caseload, and there is also a 4th room with a treatment nozzle dedicated to research. The first floor is where patient preparation and treatment takes place. We do both CT and MRI for planning, and given the high proportion of children and anaesthetic, these services are co-located on the same floor, with recovery areas, day case unit and paediatric waiting areas. As mentioned before, the centre is an open and pleasant environment to be in for both patients and staff. You can see on the bottom left there is a baby gantry used in the preparation of children for proton therapy and very kindly put together by our engineers. Children can play with this and move the couch and gantry to get accustomed to what they will experience in the treatment room. Paediatric support, of course, extends much wider than this, and there are a wide variety of services and specialists we rely on to deliver the paediatric service. Our partner in treating children is the Royal Manchester Children's Hospital, and many patients, when coming to Manchester for treatment, are for shared care. The NHS provides accommodation for children and families, and there is a school on site, so children environment. Since opening, we have treated over 500 patients, and about half of these have been children. Around 35% of paediatric patients require general anaesthetic. This is not surprising, since younger patients are increasingly being referred to us, aged 1 to 3 years old. As you can see, we treat mostly central nervous system and head and neck tumours, but we have treated a number of patients with other sites of disease. Caution must be taken, however, when interpreting these figures, as they are for the last year during COVID, and the UK prioritised the treatment of brain and head and neck tumours. If you're interested, the current NHS clinical policies and COVID framework can be found on the NHS website. In terms of histology, again, these would be expected for the case mix that we treat, and these include low-grade gliomas, ependymomas, Ewing sarcoma, rhabdomyosarcoma, and medulloblastoma, etc. An important aspect of the programme is the collection of point-of-care outcome data from patients, according to a minimum data set and defined surveillance policy. This is made possible by the pathway being entirely digital, from a referral portal through to follow-up. This includes baseline, treatment, and clinician-reported data. It also includes patient-reported data in teenagers and adults. UCH, when open, will have the same approach and will collect data according to the same agreed standard and frequency. Discussions around the development of a national proton therapy registry and outcome database are advanced. To support data collection, we have a proton clinical outcomes unit, collecting data not only from Manchester treated patients, but also patients who have been treated overseas since 2008. The data can be accessed by both NHS colleagues and academics, and the PCOU will support their research. Again, this unit is NHS funded. Since the opening of the PCOU in early 2019, the unit has seen some notable outputs, and a number of papers have been published, and a number of papers are also in press. Another aspect of the service, which is fully integrated into its operation, is education. We've provided proton education and training since opening of our service, with observerships, fellowships, and a successful proton school. The most recent proton school was delivered virtually because of COVID, but was highly successful, with over 100 delegates from 16 countries, east to west. Given the large paediatric service, we also deliver paediatric specific training to radiation colleagues nationally and internationally. So in summary, the Christie service opened its doors in December 2018. It is NHS England funded, but does take referrals from across the United Kingdom as well as the Republic of Ireland. The first patient that we treated was in fact a child, and we have treated around 250 children to date. We have extensive paediatric support in place, including play therapy and social and educational services. Outcome data collection as a consequence of clinical care is also a fundamental aspect of our service, and again NHS funded, and a proton clinical outcomes unit was established in January 2019. And both Christie and overseas treated patients are within its remit. Of the 2,400 patients that the PCOU monitors, approximately half of those are in the paediatric age group. And the PCOU has been quite successful in its academic output since its opening. We also provide an educational offering with a proton school, fellowships and observerships, and we also host National Royal College of Radiology's Paediatric Radiotherapy course every 2 years, as well as hosting radiation oncology trainees from other centres. I hope you found the presentation interesting and useful, and I'd like to thank you very much for your time. Thank you.
Thank you, Bishop, for sharing with us. And I think it was an excellent introduction to the webinar. Thank you so much. And in this 9th Faro webinar, first I will give a short introductory talk focusing on fertility preservation, hopefully to persuade you all for need of proton therapy. And then I'll hand to Dr. Uezono, who will give us lecture on proton therapy to pediatrics. So let me share my slide first. I don't know, some new page came on. For some reason, I can't share the slide. Oh. Wait. Can you see my slide? Okay.
Yes, Mariko, it's fine. Thank you.
Great, thank you. So again, good afternoon, ladies and gentlemen. Before I start, I'd like to thank Jasper and Farrell for this wonderful opportunity to talk here today. My name is Mariko Kawamura from Nagoya University from Japan. I have nothing to disclose. And because I'm a radiation oncologist, and I believe most of the participants are radiation oncologists as well, I'm not going to talk about cryopreservation of ovary or sperm, but I will focus on fertility preservation in terms of irradiating site and dose. However, I think it was a long time ago when you learned about fertility. So in order to refresh your memory, I'd like to talk about basics of fertility and then explain specifically where and how much irradiation can affect fertility. When it comes to boy, it's pretty simple. Of course, I mean, in terms of fertility, nothing more. I found this very nice figure in study published in JCO in 2018, hypothalamus secret GnRH, which acts in the anterior pituitary gland, stimulating it to release FSH and LH, which then drives spermatogenesis and testosterone production in the testes. So for us radiation oncologists, it's essential to know the tolerance dose of hypothalamus and pituitary as well as testes. However, if pituitary gets damaged due to irradiation, we can administer hormonal therapy, but for testes, if the patient is past puberty, the cryopreservation of sperm may solve the problem, but for those who are not yet past puberty, no established method exists unless testicular shielding is provided. However, today, many testicular cryopreservation trials are running, so this may solve the problem for the pre-puberty boys, but not yet available in many countries. When it comes to girls, the approach is a little more complicated. The relationship among hypothalamus, pituitary gland, and ovary is somehow similar to that seen in boys. However, girls get pregnant. An alternative is surrogacy, that is an arrangement whereby a woman agrees to become pregnant, carry the pregnancy, and give birth to a child of another woman. And this is a legal procedure in some countries, but illegal in others, including Japan. Carrying pregnancy requires healthy uterus, but that's not all. Hypothyroidism, hypertension, and overweight are all known to cause premature birth, and these can be a result of childhood cancer treatment. And this topic, fertility preservation, is very difficult for us radiation oncologists to discuss. Why? Because the tolerance dose of ovary and uterus differ according to the maturity level. Further, the beginning of puberty differ among children, And although age is a good indicator, it has a very wide range. In addition, pediatric patients almost always undergo strong chemo in combination, which by itself may cause infertility. So the currently available data on infertility due to irradiation do not concern irradiation only, as ovary or testes are damaged by chemo prior to irradiation. And most importantly, we know that radiotherapy toxicity depends on the dose, but the cure rate depends on the dose as well. So lowering the dose or blocking radiation in certain organ may preserve fertility, but we should never lower the cure rate. So we should avoid adverse effect, including infertility, as much as possible. But we have to keep in mind that they cannot become a mother or father if they are not cured. So I'll move on to some specific data we have today in infertility and irradiation. As I previously mentioned, hypothalamus and pituitary glands are important in terms of fertility preservation. It has been reported that a dose of approximately 30 gray or more may cause LH-FSH deficiency. I'm showing the risk ratio of fertility for male and female survivor who have received radiation to the head. Male subjects are compared with siblings, and the female subjects are listed as risk ratio 1 for the less than 10 gray irradiation, so you have to be careful on that. Interestingly, a dose between 18 to 50 gray is reported to cause central precocious puberty. That is, that puberty comes very early, like before 8 years old, especially in girls. This is probably due to growth hormone deficiency caused by 18 to 24 gray irradiation to the head. As you can see in this circular figure showing an overlap among anterior pituitary deficiency after cranial radiotherapy, growth hormone in the blue seems to be more sensitive than any other hormone. There is a report describing that miscarriage increases due to cranial or craniospinal irradiation with a risk ratio of 1.5 to around 2. So although sex hormone replacement is possible and effective, carrying pregnancy with insufficient pituitary glands seems difficult. The major difference from male to female is that spermatogenesis starts with mitosis. So spermatogonium would not decrease. But since spermatogonium's primary spermatocytes are highly sensitive to radiotherapy, less than 0.1 gray may kill spermatogonium in its sensitive phase, and which as a result, fractionated irradiation is more harmful than one-fraction irradiation. Moreover, since Leydig cell, the cell that produces testosterone, are less sensitive to radiotherapy than spermatogonium, azoospermia may occur with normal testosterone level. This is a very nice figure explaining the relationship of damage and recovery of spermatogenesis in terms of radiation dose. You can see that spermatogonia are very sensitive to radiation. Risk ratio of fertility in relation to the dose to testis is shown in the table. If a patient receives more than 7.5 gray to testis, the chance of preserving fertility is almost 0. And you all know that 7.5 gray won't kill any solid tumor. However, once the partner got pregnant, the pregnancy outcome will not be affected, and that is the major difference from female survivor. What about women? Unlike in men, when oocytogenesis is complete, no additional primary oocytes are created. And primary oocyte reaches their maximum development before the birth. And at the birth, this number is already reduced. And in terms of radiosensitivity, follicle becomes sensitive to radiotherapy as follicular maturation begins. As a result, ovaries in younger girls are more resistant to the effect of radiotherapy than the adolescent. So the effect of radiotherapy on ovarian function depends not only dose and fraction, but also on the patient age and sexual developmental stage. And this can be applied to the effect of chemotherapy to ovary as well. The figure here explains the relationship between age at treatment and effective sterilizing dose. The older, the lower. What about uterus? Unlike ovary, uterus mainly consists of muscle, so the tolerance dose is thought to be a little higher than in the ovary. However, female survivors who have received pelvic irradiation childhood may experience disruption of normal uterine function as well. It has been reported that babies are more likely to be premature, have low birth weight, be small for gestational age, and have higher risk of mid-trimester miscarriage, probably due to the reduced uterine volume. High-dose estradiol replacement has been shown to increase the uterine volume and the endometrial thickness in postmenopausal women, which rendered postmenopausal women capable to surrogate birth. However, a Danish report showed that after certain dose, in that report it was 30 gray, irradiation to the uterus, irreversible damage occurred in uterine, and high-dose estradiol replacement did not improve the uterine volume. This is understandable because high dose may cause fibrosis due to the damage caused in the uterine vasculature, and fibrosis is usually irreversible. However, it is not certain whether 30 gray is the limit or not. In another report, a damage caused by a dose of 20 to 40 gray may be reversible with the use of anti-fibrotic agent like vitamin E. This too seems to be affected by maturity level of uterine. Today, however, uterine transplants are available, so technically fertility can be maintained in patients who have undergone pelvic irradiation. However, there are ethical and legal restrictions on transplant and surrogacy, so it is necessary not to irradiate pelvic as much as possible with currently available technology. So what kind of data do we have in terms of pelvic irradiation and fertility in female survivor? We know that relative risk of pregnancy lower as the radiation dose to pelvic increases. It has been reported that the patient who have very small chance to be pregnant with more than 10 gray irradiation to pelvis. At this point, the risk of stillbirth and miscarriage are reported not to increase with irradiation to pelvis. However, another report found that high dose irradiation to uterus may increase mid-trimester miscarriage. So we should be very careful about the dose irradiated to the uterus, especially nowadays because today hormone replacement therapy, ovary cryopreservation techniques, and oocyte donation are all available. Therefore, the capability of getting pregnant may increase. Another important concern is whether irradiation to ovary or testis can increase the risk of genetic disease in the newborn. It has been reported that cancer treatment, including radiotherapy, does not lead to a higher risk of genetic disease in the offspring. However, with very limited data, we should still be very careful. So is there anything we can do today as radiation oncologists to preserve fertility? I think you have seen this picture in past. This is from Red Journal. The dose conformity is of course excellent if we use IMRT, but with proton, you will not irradiate structures that are anterior to the vertebral column. So while irradiating GSI, so that means the uterus, ovary, testis, and thyroid are not irradiated, and this is why we want to use proton for pediatric patient. So that's all from me, and I'll stop sharing the slide. So before we move on to Dr. Uezono's lecture, I would like to introduce him briefly. So Dr. Uezono can start getting ready for his presentation while I'm giving his introduction. So Dr. Uezono graduated from Kobe University School of Medicine in 2003 and completed radiation oncology residency in 2009. He spent most of his career at Hyogo Cancer Center and Kobe Minimally Invasive Cancer Center before he joined the pediatric proton therapy fellowship And he joined the Pediatric Proton Therapy Fellowship Program at University of Florida in 2017, followed by SRS SBRT Fellowship at Yale University. Currently, he is an attending radiation oncologist at Hyogo Cancer Center and Kobe Proton Center. And so, Dr. Uezono, are you ready? Can you share the slide?
Sure.
And to the participant, if you have any question, please write in Q&A during the lecture so that we may be able to discuss in the panel discussion. So Dr. Uezono, it's all yours.
Do you see my slide?
Yeah, but it's somehow cut it in, yeah,
Hello.
it's good.
Okay. Thank you, Dr. Kawamura, for a kind introduction for me. And hello, everyone. My name is Haruka Uezono from Radiation Oncology at Hyogo Cancer Center and Kobe Proton Center. Before I start my talk, I'd like to thank Faro Education and Training Committee, as well as JASTRO International Committee, for giving me this exciting opportunity to present at Faro Webinar. There's no COIs to disclose. So for this talk, I will start with the overview of pediatric oncology, and then I'll show you some physics and biology aspect of the protons. I'll show you some clinical evidence of pediatric proton therapy focusing on pediatric brain tumors. And then I'll talk about what we do, how we do in Japan, just briefly, and some future directions. So overview. The characteristics of the pediatric tumors are represented by these three keywords: rarity, diversity, and curability. Each year, 2,000 to 3,000 new cases are diagnosed in Japan, corresponding to one case in 10,000 children. There are a wide variety of tumor types, histologies. Genetic disorders are frequently encountered, and each child has a different developmental stage. Oftentimes, treatment requires multimodality therapy, including intensive chemotherapy, aggressive surgery, and radiation. Favorable response to therapy are anticipated, although many cases are diagnosed at advanced stages. And long-term survivals are expected, even with metastatic disease, which wouldn't be expected in adult cancers. 70 to 80% achieve cure. So this graph shows the trends in survival rates of pediatric tumors since 1970s in 10 different tumor categories. With the improvements in diagnostic and treatment modalities, more children are living longer. This data is from Childhood Cancer Survivor Study, looking at more than 20,000 pediatric patients who lived longer than 5 years between late 1970s to early 2000s. The graph on the left shows the cumulative mortality on the y-axis and the time from diagnosis on the x-axis. And if you look at the blue line indicating recurrence or progression-related mortality, it plateaus at around 15 to 20 years after diagnosis. However, if you look at the yellow line indicating no recurrence or non-external cause-related mortality, which means treatment-related mortality, it exponentially increases at around 25 to 30 years after diagnosis. And this data also indicated that the radiation therapy increased the risk of cardiac death and death due to secondary malignancy by approximately 3 times. So this data raises a huge concern for late toxicity from treatment, particularly from radiation therapy. This graph shows the trends in the use of radiation therapy as a part of initial therapy for pediatric tumors. They studied the data from SHEAR between early 2019 and 2017 to late 2000s. And they found decline in the use of radiation therapy in 7 out of 10 disease categories. But this was not because the radiation was ineffective, but because of the concern for both acute and late toxicities from radiation. However, we know that radiation would still continue to be the essential component of multimodality therapy. So what is important is we give lower radiation doses to smaller volumes. And I think the proton would be one solution. Now let's move on to the physics and biology. This graph shows the relationship between the radiation dose on the y-axis and the penetration depth on the x-axis. And as you hit a proton into a patient's body, it travels through to a certain depth determined by its energy, and it delivers a high dose of radiation called the Bragg peak, and it immediately stops within a few millimeters. But you can treat only a tiny spot within the tumor with a single proton. So you need many more protons. You need many more protons to cover the entire tumor. And the summation of these green lines would be the yellow line, creating a clinically relevant dose distribution to cover the entire length of the tumor, called spread out Bragg peak or SOBP. So if you compare protons with photons or X-rays, the X-ray is a packet of energy. There's no mass with photons. It enters the body and delivers a relatively higher dose of radiation in front of the tumor. It hits the tumor and exits through the patient's body. The protons delivers a relatively lower dose of radiation in front of the tumor, hit the tumor, and stops at the distal end of the tumor. There's no exit doses. So in order to deliver the same dose to the tumor, photons must deliver a greater dose outside the target than the protons do, indicated by this red area on the figure. This is not a physics issue, rather a technical issue, but something I'd like to share with you. On the left side of the screen, you see passive scattering technique or broad beam technique. So if you fire the beam, as the beam exits through the compensator, the tip of the beam is formed to fit the shape of the tumor. However, there's an unwanted dose shifting toward one end of the beam. On the right side of the screen, you see scanning technique, also referred as pencil beam scanning or spot scanning. You deliver each tiny spots of proton within the tumor to create a highly conformal dose distribution within the tumor. The shortcoming of this technique is less robustness. So we typically don't apply this technique for tumors with organ motion. Just a single slide of biology. If you compare proton with photon and carbon, in terms of LET or linear energy transfer, the carbon has the highest LET and the photon has the lowest LET. LET is density of energy within a certain length of a radiation track. So high LET is like a machine gun, low LET is like a pistol or handgun. In terms of DNA damaging process, photon cuts the DNA predominantly via indirect effect, while the carbon has the double helix, mostly with direct effect. And proton is considered somewhere in the middle. The RBE, relative biological effectiveness of the proton, is considered 1.1. So equivalent or slightly higher compared to the photon. However, the story is not that simple, so I will talk about more in detail later. Clinical evidence. This is a 4-year-old child with a left orbital rhabdomyosarcoma. On the left, you see proton plan, on the right, IMRT plan. and the target coverage within the left orbit is quite similar. However, you see a significant scattering dose within the brain with the INRT. Those low to intermediate dose in the brain might be negligible in adult patients. However, that is not the case with pediatric patients who are growing. Particularly the brains are radiation sensitive organ. Now I will focus on the brain tumors and see how we can apply the advantages of proton therapy. This study from Dutch looking at nearly 300 pediatric cancer survivors who received brain radiation, photon-based radiation, and 80% of them developed at least one adverse event. And nearly a half of the survivors developed at least one severe, life-threatening, or disabling events, which seems unacceptably high to me. Again, its brains are radiation sensitive. Now, specifically looking at cognitive impact of radiation and see how we can improve with proton. This is a 4-year-old child with a posterior fossa ependymoma. On the left, you see proton plan, the PMAT plan on the right. At the bottom, you see a GBH table comparing both plans. And the target coverage is equivalent or slightly better with the protons. However, if you look at the normal component of the brain, the proton delivers far less dose to the temporal lobes, hippocampus, and cochlea. So why do we minimize the radiation dose to the temporal lobe? On the left side of the screen, you see graphs showing the risks of cognitive impairment on the y-axis. And on the x-axis, you see the temporal lobe radiation dose. And I broke this color bar from the radiation plan on the right. So the blue line indicates 15 gray line, and the orange indicates 50 gray. And you see a steep increase of the risk in each domain at around 15 to 25 gray range. So 15 blue to light green area. And this exactly corresponds to the area where you see the most difference between the protons and INRT plan. So with protons, we expect relative gains in task efficiency, processing speed, and memory. So this is just a theoretical modeling data, and now we are getting early clinical outcome data. This study looked at neurocognitive outcomes following either proton or photon for pediatric brain tumors. They evaluated 125 patients with brain tumors, 58 received proton therapy, and 67 received photon therapy. After a median follow-up of 3.2 years, patients who received proton therapy gained significantly higher IQ scores compared to those who received photon therapy in most domains of the function. If you look at the follow-up period, you see a significant difference between the two cohorts, with the photon cohort being longer followed up. However, after adjusting the differences of follow-up period, proton was still associated with improved full-scale IQ, verbal IQ, and processing speed. This study specifically looked at pediatric medulloblastoma and compared the cognitive outcomes either with proton or photon. 79 patients with medulloblastoma were evaluated, meaning all these patients received whole brain and whole spine radiation to at least a dose of 23.4 gray to 36 gray. 37 received proton and 42 received photon therapy. After median follow-up of 4.3 years, patients who received proton therapy, indicated by these blue lines in the figure, maintained higher IQ scores in most domains compared to those who received photon-based therapy, indicated by the red line. Processing speed, however, was a vulnerable domain in both groups, and this might be affected by impaired fine motor function related to the tumor location of the posterior fossa, rather than pure cognitive impairment. Now moving on to endocrine impact. This is a 8-year-old with a low-grade glioma of the right temporal parietal lobe. And you see significant dose reduction in the left temporal lobe with the protons. So we expect reduced risk of cognitive impairment with this plan. But if you look at the hypothalamus, IMRT delivered a mean dose of 27 gray to the hypothalamus, while the protons delivered only 0.8 gray. So why do we care about the hypothalamic dose? This study, published by Tom Marchant from St. Jude, looked at the peak growth hormone level after radiation therapy to the brain on the y-axis, and the x-axis shows the time from radiation therapy. And each colored line indicates the radiation dose in the hypothalamus. And as you see, with higher dose of radiation in the hypothalamus, you see exponential decrease in the growth hormone secretion. On the right side of the screen, you see the table showing probability of growth hormone deficiency after 5 years from treatment, stratified by mean hypothalamic dose. So if you recall the patient in a previous slide with a low-grade glioma of the right temporal parietal lobe who received 27 gray to his hypothalamus, he had a chance of approximately 80% of developing growth hormone deficiency after 5 years from treatment. So growth hormone deficiency is a serious problem that contributes to a number of health-related issues. This is a combined results from MGH, MD Anderson, and Emory, where they looked at patients treated with either with protons or photons or for medulloblastoma. The dosimetric comparison for the CSI demonstrates that the proton delivers far less dose to the hypothalamus, pituitary gland, and thyroid gland. And this dosimetric advantages translated into clinically better outcome in reducing the risk of T4 deficiency, sex hormone deficiency, requirements for any hormone replacement therapy, and decreased height with the proton. Now moving on to secondary tumors. This is a plain comparison of a cranial spinal irradiation in a girl. The top shows the proton plan, and the bottom shows the photon plan. And you see a remarkable dose reduction anterior to the spinal column with the proton. This study from Paul Scherrer Institute from Switzerland estimated the risk of secondary cancer following cranial spinal radiation using either with conventional photon, IMRT, or protons. And they estimated the risk of secondary cancer following proton-based CSI is much lower compared to the conventional photon or IMRT. This is just a theoretical model data. And here's clinical data. This article on the top is a meta-analysis looking at the risk of secondary tumor after photon-based cranial spinal radiation for medulloblastoma. They looked at over 1,000 patients with medulloblastoma, and they found a 10-year cumulative incidence of secondary tumor was 6%. The majority of these tumors occurred in the area of exit doses. At the bottom is a single institution outcome data from MGH, looked at long-term toxic effects, including the secondary cancer from proton-based cranial spinal radiation. They looked at 59 patients with medulloblastoma. After a median follow-up of 7 years, no secondary tumor was observed. This table shows the combined results from a review article published several years ago and 2 single-institution recently published articles. Overall, the number of patients in each study is small, and the follow-up period might be insufficient. However, these early clinical outcome data is encouraging, with the risk of secondary tumor being mostly 0 to 5% at 10 years. I talked about the advantages of proton in reducing the risk of cognitive function, risk of endocrine impact, and reducing the risk of secondary cancer. And there are some other advantages of proton, including reducing the acute toxicity from cranial spinal radiation, better quality of life in pediatric brain tumor treatment, and better cost effectiveness with protons. As you know, most of the long-term side effects from radiation will last for years, decades, or lifelong time for those young children. So proton therapy is expensive by itself. However, in the long term, it will pay off. So in summary, low to intermediate dose is critical for normal developing tissues in children. Proton therapy can be used to reduce the amount of normal tissue that receives collateral radiation. Current clinical data substantiates the modeled dosimetry benefit. So no downside with protons. Certainly the proton is expensive. It requires highly specialized team. But here's some caveat that I would like to share with you. This study from MD Anderson looked at 72 patients with ependymoma. About half received proton therapy, the remaining half received the IMRT. And post-treatment MRI changes occurred in as many as 43% of the proton cohort versus 17% in the IMRT cohort. And the MRI scan from post-proton therapy, day 10, you see no remarkable change. That after 4 months from treatment, you see increased signal change in the posterior aspect of the brainstem within the high dose area in the proton plan. But you see no remarkable changes noted in the cerebellum, which is also within the high dose area, only in the brainstem. In the experience of University of Florida, where they looked at 114 posterior fossa tumors receiving median dose of 54 grade proton therapy, they found grade 2 or greater brainstem necrosis in over 10%, which seems high. So this data raises concern that proton might be hazardous for pediatric brain tissues, or it might be a matter of radiation dose rather than radiation type, or while the patient's too young, or effect of chemotherapy or surgery. Earlier, I talked about the SOBP, which is like the blue line on the figure. The physical dose along the SOBP is constant. This study looked at the cell-killing effect of a proton at several different depths in the water. And they found significant increase of the relative biological effectiveness toward the distal end of the SOBP to a maximum of 1.8 times compared to the baseline. So this might be related to the increased risk of brain injury with the protons, as we saw in the previous slide. Imagine there was a tumor here, and the brainstem was here. And it is reasonable that something unexpected might be happening in the surface of the brainstem. So the proton therapy expert consortium from the United States recommend limiting the brainstem exposure to the distal aspect of the SOBP, typically no more than 1/3 of the beams ending in the brainstem. Currently, biologically adjusted planning software is under investigation. And this figure at the bottom left from MGH shows a normal proton plan using the RBE value of 1.1 at the top and using the RBE value of 1.2 of the product. And you see an increased biological effectiveness in the posterior aspect of the brainstem as they used multiple posterior beams ending in right in front of the brainstem. Current status in Japan. We have 17 proton centers, 6 carbon centers, and 1 dual ion center in Japan. Most of the centers are located in well-populated area in between Tokyo and Osaka. But there are several other centers in the north and the southwest. So particle therapy facilities are well distributed across the nation. This is where I live. I live in Kobe City, which is the capital city of Hyogo Prefecture. I believe Kobe City is famous for the best beef in the world. We have beautiful sceneries. And there are 5.5 million people living in Hyogo Prefecture, and it borders Kyoto and Osaka to the east. So southeast Hyogo, northern Osaka, and southern Kyoto, this area is the second largest city in Japan, next to Tokyo. So we have 2 particle therapy facilities in Hyogo Prefecture, both of which are operated by Hyogo local government. And Hyogo Cancer Center, where I mainly work for, is in between. If you compare the 2 centers, Hyogo Ion Beam Medical Center is one of the pioneers of particle therapy in Japan. It opened in 2001. Kobe Proton Center opened in 2017. HIBMC has a huge synchrotron where you generate the particle therapy beam, while the KPC has one of the smallest, latest type of synchrotron. HIBMC is one of a few dual ion centers all over the world where you can have both proton and carbon. Only proton is available in KPC. HIBMC is a little bit isolated in location. It takes about 2.5 hours from Kobe city center. It takes only 15 minutes from Kobe downtown to KPC. And Kobe Proton Center, here on this figure, is connected to Kobe Children's Hospital, which is also operated by Hyogo local government and one of the highest volume center of pediatric care. And in between Proton Center and the Children's Hospital, there is the Ronald McDonald House, which is a charity accommodation for pediatric patients and their families. And we transferred pediatric proton therapy function from HIBMC to KPC in 2017. About half of the patients we treat have brain tumors. 20% have sarcomas, 14% with neuroblastomas. If you look at the breakdowns of these tumor categories, brain tumors are comprised of mainly of medulloblastoma and ependymoma, some intracranial Johnson tumors, and ETRTs. Sarcomas include Ewing sarcoma and rhabdomyosarcoma. And if you compare these results with the international survey results published in 2019, the fraction of disease categories are quite similar. We have more neuroblastoma cases instead of head and neck cancer cases. We have more intracranial Johnson tumors compared to the Western countries. The cost of proton therapy. So particle therapy was not approved by the National Health Insurance of Japan until 2016, when pediatric proton therapy first became to be approved by the National Health Insurance. Currently, both proton and carbon are approved in the treatment of unresectable bone and soft tissue tumors, non-squamous cell head and neck tumors, and prostate cancers. The cost of pediatric proton therapy per case is approximately 2.4 million Japanese yen. For your reference, I prepared the exchanged cost that covers most of your currency. And the health insurance pays 70% of the total cost. So patients are expected to pay the rest 30%. Still expensive. So further reimbursement can be expected from your local government depending on where you live and your household income. In 2020, we treated 218 patients in 20 particle therapy facilities all over Japan. The graph shows the number of patients each center treated on the y-axis and year each center opened on the x-axis. So we opened 2017 and we treated more than 70 patients last year. So we are here. So about 1/3 of all Japanese pediatric patients who received 20 in 2020, who received proton therapy in 2020, came to Kobe to have proton therapy. And our experience of pediatric proton therapy is back in early 2000s with HIV and C. So I believe we have one of the most experience in this field. Experience is important. This article on the top is a systematic review looking at the volume effect in pediatric oncology. It demonstrated that children with brain tumors and sarcomas treated in high volume centers have a better survival compared to those treated in low volume hospitals. The other article in the bottom looked at the survival impact of radiation therapy in the treatment of pediatric medulloblastoma. And it demonstrated that treatment in high volume center nearly doubles the chance of survival. So I think it is important to discuss in your community or society if you should consolidate or distribute proton therapy facilities for pediatric patients. The more consolidate, the higher the quality of care would be, but less patients access. The last section, future directions. This study, COG D9803, looked at the local control for intermediate risk rhabdomyosarcoma. And they found tumors greater than 5 centimeters were more likely to fail locally, indicating that the standard dose of 50.4 gray might be insufficient. So currently ongoing ARSD 1431 is examining the dose escalation protocol for bulky tumors. These two retrospective data from St. Jude and the University of Florida looked at the local control for Ewing sarcoma using the radiation therapy. And they found excellent local control even for bulky tumors if they used 60 gray or higher dose of radiation. So these data indicates that we need more radiation to achieve better local control. But how? Typically, bulky tumors are affecting critical organs that would not tolerate 60 gray or higher. So we previously used a spacer for tumors in pelvis or abdomen that is close to the critical organs. However, it harbored some risk of late complications, including GI perforation, ureter obstruction, or infection. And we thought this could be unsafe for growing children and wanted to develop a new type of spacer. By collaborating with Kobe University and its affiliation, we developed a bioabsorbable spacer that is made of polyglycolic acid surgical sutures. It maintains original thickness for about 8 to 10 weeks following placement, and then gradually shrinks and disappears after 9 to 10 months. We completed phase 1 study with 5 pediatric patients without any concerning issues. This is a 15-year-old girl with a pelvic chondrosarcoma. Pre-chemotherapy imaging shows a bulky tumor centered in the bladder neck area. Post-chemotherapy imaging shows a remarkable reduction in size, however, still remains in between the pubis and bladder. So we plan a spacer placement to push the uterus back. This is post spacer placement. This white thing is the spacer, and the uterus and GI tract is pushed back with the spacer. And the proton plan shows nice target coverage in the tumor bed while minimizing the radiation dose in the uterine body and GI tract. So we are anticipating improved local control in certain types of tumor with safe spacer placement and high dose radiation with proton therapy. So for conclusion, there is no level 1 evidence showing the superiority of proton over photon. However, there is a decent amount of data showing that proton therapy is associated with less acute and late toxicities while maintaining equivalent tumor control outcomes. Higher radiation dose with proton therapy may improve local control in some types of tumor. We will continue longer follow-up and collect data from both prospective and retrospective studies to validate the advantages of proton therapy. Thank you so much for your attention. I would like to thank my colleagues and mentors from Hyogo Cancer Center as well as Kobe Proton Center. And special thanks to Danny Delgado from the University of Florida, who pulled me in this challenging but rewarding field of pediatric radiation oncology. Thank you again.
Thank you, Dr. Uezono, for very well organized presentation. And I think we all have great knowledge. We have heard great knowledge of proton therapy. And so now we want to panel discussion. Can panelists turn on your camera? So today we have 4 panelists with us, and to start, can you all give us a little introduction of yourself? Are you treating pediatric or are you using proton therapy? And also, is the use of proton for pediatric treatment accepted as a standard of care in your country? If not, what's the problem? So can Dr. Lashka start?
Hi, hello everyone. And first of all, I would like to thank Jastro and Faro for organizing this very nice and interesting and informative meeting. It is extremely relevant at this time in our part of the world, especially with the machines that we are installing everywhere. I come from Mumbai, and I work in a institution called the Tata Memorial Hospital. And so this is a large comprehensive cancer center where I work in. We register about 75,000 new cancer patients every year. And the pediatric population, of course, is slightly smaller than that number. I specialize in pediatric oncology. I also treat bone and soft tissue tumors and hematolymphoid malignancies. Just to give you a feel of the numbers of patients in numbers of children, we overall we see about 3,000 children below the age of 18, which includes both CNS, solid tumors, non-CNS, and hematolymphoid malignancies. So there is a large number of children that we see in our hospital, and in a year in the radiation department, we end up treating about approximately about 500 children every year, which includes both CNS and the non-CNS tumors. So, so that's about the institution where I come from. Just to give you a background of the status of proton therapy in India, we have one center in a private institution in Chennai, which is functional, which is it's a 2 gantry facility with a fixed beam. They've been functional for the last 1.5 years, and they're doing good work. We in TMH, we are also installing our proton therapy facility, and we hope to be functional by the end of the year. And we are going to have a 3 gantry facility from IBA, Proteus Plus, and all 3 gantries are with PBS, the pencil beam scanning. So we are looking forward to starting our proton therapy. Do we use proton therapy currently in our country? Yes, I'm aware of the fact that there are children, especially with brain tumors and all the other indications that we discussed in those 2-3 very nice talks that we heard as of now. So the indications are more or less the same. And we will obviously in our institution be focusing to a great extent on protons for pediatric age group. So that's a brief overview of where I come from, the institution where I come from. We have a huge focus on service research and education, like you heard from in the talk from Manchester. It's a very similar principle that we are following, and we would look forward to collaborating with all of you who have so much of experience using protons. So your experience would be for our benefit, actually. So thank you very much for allowing us to join you in this meeting. Thank you.
Thank you, Dr. Lashka. So Kanjana, can you give us your background as well?
Afternoon, everyone. My name is Kanjana Chodwasak. I'm from Chulalongkorn University, Bangkok, Thailand. First of all, I would like to thank Faro and Jastro for giving me an opportunity to be in a panel discussion. And also I would like to thank Dr. Uresono and Dr. Kawamura for the interesting lectures. Yeah, I think that's going to be very benefit for us. In Thailand, I have to say that we are very excited that we just have first proton facility in our country. Yeah, that is in our hospital in Chulalongkorn University, and we just start treatment a few weeks ago in August. Yeah. So very, very new for us. So we are so excited and we have lots of things to learn. Yeah. Actually, I have a few slides to show you about my center. Yeah, my proton. Let me share my slides. Okay, this is our proton facilities in Chulalongkorn University, Bangkok, Thailand. Yeah, our proton machine is a compact probeam. Yeah, and we just start, as I said. Yeah, so what we gonna do right now for proton treatment? Yeah. I think as I think all our radiation oncologists, I think we all know that for pediatric groups, that's gonna get benefit from proton treatment to reduce the normal tissue dose. So for sure that pediatric cancer is one of our target that plan to start with proton. And also we plan to start with other adult tumor like hepatocellular carcinoma and also the esophageal cancer. And for pediatric cancer, as Dr. Sonot talked that maybe we can treat just both CNS tumor and non-CNS tumor, but with our limitations because we have one proton machines and also one gantry. It's one gantry, so one room. So that's going to be the limit that we may not be able to treat many patients, and also with the limitations of the cost of treatment. So we need to see what patients are gonna benefit most for proton. So right now we plan to start with the CNS tumor. And first, we plan for the craniospinal irradiation patients. Yeah. So maybe I think your lectures help us a lot to see what patients that gonna benefit from proton, and maybe I have like a few questions after this, like which patients that you think that in the that we have some limitations, which patient that we should start, yeah, or which patient gonna benefit most from proton, yeah.
Thank you. Yeah, we can discuss on that after all four have introduced themselves. So Dr. Jeffrey Tran from Singapore, can you give us your introduction?
Hello, hi, good evening. Thank you to Jastro and Faro for inviting me to be on the panel. I work at the National Cancer Center in Singapore. Actually mostly treating adults, so urology and gynae patients. But most recently, actually, I treated a 11-month-old child with a prostate rhabdosarcoma. And because protons is not available yet in Singapore until about 1 or 2 years time, we actually gave the patient brachytherapy. So whichever way that you can give high dose to the area to reduce long-term toxicity. I think shortly after that, we had the patient with rhabdo myosarcoma of the orbit, and we looked at Dr. Laskar's series where he implanted brachytherapy tubes into the eye, into the orbit, and we tried to reproduce it as much as well. And patient had surgery done, and then we treated the tumor bed, and both patients have done well with brachytherapy. So although the focus here is on proton therapy, but I think any way of very conformal, localized, effective radiotherapy is very relevant in adults and also in children to reduce the risk of long-term toxicities. So Singapore is going to have 3 proton therapy centers, 2 private and 1 national. So the National Cancer Center is being built right now. And in fact, due to COVID, as with many hospitals, there are delays. I think we were due to open last year, but more likely next year will be fully open, and the proton will start 1 year after, which means probably 2023. We're going to have a 4 gantry system plus 1 room dedicated for research. So very similar to what the Manchester system is. And there is a plan to co-locate animal and cell laboratories close by with a dedicated lift that provides access from the labs to the research center to look at basically RB calculations and so forth. The indications here in Singapore, there have been some discussions, and pediatrics is going to be approved for all solid tumors, and we have defined the age as about from 20 years and below. So not just 18, but we expanded it to age 20. So hopefully we can benefit more patients in this age group. The other adult tumors that are likely to be approved would include locally advanced head and neck cancers, lung cancers, prostate cancer, and also certain types of lymphomas. So it's going to be in kind of like limited indications at the moment, and I think that is really to control the influx of patients, and also because protons is a very costly treatment, the government wanted to manage costs. So again, these things will evolve as we get more and more data in terms of proving that protons is cost effective in the long term. And we have a plan just like the Manchester Group has for prospective long-term database collection. And I understand in Japan as well, there is a national registry of such data. And I think in the region, we should all try to combine some of our data so that we can have more power in terms of statistical analysis that will allow us to reach the endpoint sooner rather than wait maybe 5 or 10 years. Thank you very much.
Thank you. So Dr. Oshiro, can you introduce us your point of view?
Hello, I'm Yoshiko Shiro from Japan. I belong to Tsukuba University, and we have treated pediatrics with proton since 1984, maybe the first time in the world. I think proton therapy is considered as a standard therapy in Japan, as Dr. Uezomo and Dr. Nagata told us before. But however, the capacity, institutional capacity and patient access has been still limited in Japan. Thank you.
Thank you. So a lot of you are treating pediatrics or using proton, so that's why you guys are the panelists. But so unfortunately, there's no question from the participants. So I wanted to ask. I hate to say this in the beginning, but money talks, and proton therapy is costly. And I heard Japan and Singapore are covered with the national healthcare insurance. How about India? Because you guys have a lot of patients, 3,000 pediatrics with national coverage costs huge.
So, yeah, so what we are planning is that we'll have a 3-gantry system, and we plan to work 16 hours a day. I would say effectively 14 hours a day. And with this kind of a facility, we propose to treat about 800 patients a year. I don't know, the experts can tell me whether there's the right estimate or not, but I guess we should be able to do it. And what we intend to do in our center is that we are a government hospital, and we are the funding for this hospital comes from from the government. It's not a privately funded. So it's our mandate that a proportion of our patients have to be treated free of cost. So what we are planning is that 50% of our patients would be treated completely free of cost, or maybe very minimally charged, and the remaining patients would be charged for the treatment. So our thinking is that we should charge only that much which is necessary to really run the hospital. So that's how we are thinking of, even without any funding from external agencies or insurance. That's how we are thinking of starting off right now. But the government has got multiple initiatives now. Even the Prime Minister now has the Prime Minister's Health Insurance Initiative, and they are formulating standard guidelines of charging patients for radiation therapy, surgery, chemotherapy. They'll be very standardized costing across the country so that they are uniform. So that is going to come, and that is going to benefit a large number of patients within the country who would be in a way covered by insurance. So in the long run, we are looking at insurance covering our proton therapy. Currently, it is covering standard non-proton radiation therapy, but in the long run, we are looking at. So insurance will come in the long run, but that's a very small proportion right now. So that's how we are looking at funding our patients. How do we triage our patients? That will be a big question, because we'll have loads of patients who would be wanting to come for proton. There will be people with money who would be wanting protons. But what we have done is we are going to follow something similar to what Groningen follows. Groningen has a modeling system. We are looking at patients where we are not very sure of the potential benefit of protons. We are going to do a plan on X-rays, on photons, and then compare dosimetrically, and maybe those patients who do not fit into those constraints with X-rays will probably go into protons. So every disease management group has been given this mandate currently to work out the way they are going to triage their patients to receive protons. And we know that about in a large comprehensive cancer center, about 15 to 20% of patients who come for radiation would potentially benefit with protons. But I would leave that answer to the experts who have been treating with protons. I'm just talking theory here, but this is what I get to know from the experts, and also my friend Danny and Delicato, who's and people like them. They give us inputs. So that tells me that about 15 to 20% of patients who come to a radiation department could potentially benefit with protons, and that value could go up if you are primarily treating pediatrics. So pediatrics, of course, it will go up a little bit more, but overall, that's the kind of calculation that we are looking at. But as we start treating, we will know whether we are correct practically or on the basis of our theoretical knowledge.
Thank you. I think it's somewhat connected to what Kanjana has pointed out. I mean, who would really benefit from proton therapy? And there's a question. If you can see Q&A, and there is a question from Indonesia asking, treating diffuse intrinsic pontine glioma, is there any superiority using proton compared to photon? And those kind of things. So can Dr. Uezono first give your point, and then maybe if all the panelists have some comment, then you can share. Dr. Uezono, can you answer?
So I personally, do you hear me?
Yes.
I personally think DIPG or high-grade glioma with gross residual disease, those patients have extremely poor prognosis. And I personally think those patients with poor prognosis have the lowest priority for proton therapy because they wouldn't be benefited from the reduced risk of long-term effects from the radiation. That's my point.
Is there any other opinion from panelists?
I don't treat brain tumors, but just before the meeting, I asked my neuro-oncology colleagues, which are the pediatric brain tumors that you would not treat using protons. So they said two diagnoses. One was glioblastoma, and the other one was DIPG.
I agree.
Too poor prognosis. Okay,
Yes.
I see. Do you have different opinion, Kanjana?
Yeah, I totally agree with all of you that pontine glioma or DIPG is very poor prognosis, and I don't think that in this poor prognosis, proton gonna have like significant benefit. Yeah, for us right now, I think for DIPG now we try to do hypofractionation with photon. Yeah, because some patients come with the clinical not that good. So we try to finish radiation treatment as soon as possible. So as there are some data, some study of hypofractionation in DIPG that show that seems like no significant difference in survival. So right now we reduce fractions to like 20 treatment. Yeah, with with photon treatment. Yeah.
Okay. So. Oh yeah, you can tell that to the parents. So they just want to focus on the technique. That's the that's asking the Q&A, but that's pretty difficult. It's limited. The source is limited, so we have to select patient, I believe. So how about Jeffrey? You are treating adults and proton for quite long. So how long to plan cranial spinal if you are to treat?
Yeah, so just to explain, we haven't really started treatment. It's going to be probably, the center will be ready in about 2 years, but we are doing a lot of planning studies to look at the techniques. And I think that for CSI, depending on the length of the patient, whether it is a young child versus a adolescent, the timing can increase depending on the number of junctions that you require and the imaging that you do. So I think that an estimation for us for each pediatric patient is at least an hour or more slots, and that's going to be challenging in the very busy proton center. And also, I think as what was highlighted by the Manchester group, also was the need for anesthesia. So if you can actually avoid the use of anesthesia, then possibly you can reduce the beam room time, which will compete with the rest of the patients. So for a center with limited rooms, like a single room, then that will be very challenging if you only have a certain limited number of 1 hour slots. And so in our center, when we start, we plan to have a dedicated room for peds, and then while the other rooms can be used for adults. And that will also allow us to design the room to be child friendly with paintings of the cartoons and all these things. Looking at also painting our thermoplastic masks, to make them feel like they're superheroes. These are and also engaging the child life specialists. So I'm very impressed with the Manchester setup with all these investment, and also very impressed that they have dedicated 50% of their patients to treating children, which we all know that it is not financially viable, but it's very important.
Yeah, I'm sure Dr. Oshiro has treated a lot of pediatric CSI, and how long a patient with who need anesthesia will take one room, occupy the room. The microphone's off.
Sorry. So it takes very, very long time. So we try to give so how can I say training for patients without anesthesia. So for example, we play patient with in the treatment room or some characterized mask. So as possible, we try to treat patients without anesthesia. So if we need anesthesia for very young children, maybe younger than 3 years old, it takes more than 30 minutes or more.
About 30 minutes.
Or more.
At most, or more.
Yeah, or more.
How about in Hyogo, Dr. Uezono? How long will it take for the CSI for pediatrics?
I think it takes about an hour or more in our institution, depending on whether the patient requires sedation or anesthesia or not. So at the maximum, it could take an hour and a half, I think, depending on the number of fields or junctions.
So how many children per day can you treat in Proton Center in one day maximum?
So in Hyogo, I think the maximum of patients requiring sedation per day was, I think, 3 to 4. So the rest of the hours would be used for non-sedation patients. So we typically treat about 5 to 7 or 8 pediatric patients per day, I think. So not too many, but not too few.
I have a question about CSI. Yeah, I know that in the patients who need anesthesia, that's sure that we need to do in supine position. I don't know if the patients like older enough to lie prone. Do you think, and they can, if they can tolerate, he can tolerate prone position. Do you think prone position has benefit comparing with supine position for CSI?
I didn't exactly. Are you asking? Do you want to ask Dr. Uezono for that, or everyone?
Yeah. Also, you, Dr. Uezono or Dr. Oshiro, that you mentioned about craniospinal radiation.
Dr. Oshiro, can you
Yeah.
answer?
So you mean,
If the patient can lie prone, yeah.
yeah.
Yeah, I'm not sure that is there any benefit for prone position comparing with supine position, proton.
No, we treated just lie on the bed. What prone position? How can I say? So we treated patients just lie on the bed and
Like
not prone
supine,
position.
supine position, right?
Yeah.
Okay.
So
Okay.
I think if prone position intensity maybe it is some distance from spinal and intensity. There may be. So I think it may be a benefit for prone position, but we don't
Yeah.
use prone position.
Yeah. Maybe because I don't have experience, but I just think that most we can use posterior feel, right? Usually posterior beam to the spine and the brain. I'm not sure, is that correct, or what kind of beam that you use?
So one reason so we use we radiated brain whole brain radiation by X-ray. So X-ray and spine for spinal radiation we use proton. So yeah, there is a gap. So the same position is necessary. So maybe prone position is difficult, I think.
Thank you.
Sorry.
Thank you.
If I can ask a question to the ones who are treating with protons, Dr. Uezono, probably you could answer the question. My question is regarding the planning that we do now. And as you and Dr. Smith very clearly highlighted, that there are uncertainties. And one of the uncertainties in proton planning is the end of range RBE. And the newer systems do incorporate LET-based planning. So what is your take on the status of LET-based planning now? That is number one. The second part of the question is, is there a big utility of a dual energy CT scanner for acquiring images? Because we know that it is all based on the calculation of stopping power. So does it help us? Because we are in the process of actually getting our CT scanners. So we are debating whether we should have a dual energy. So you having treated patients with protons, do you think dual energy CT scanner would help us in treatment planning? So 2 questions for you, and any of you can answer actually.
So I have no idea in terms of the dual energy CT. We don't use that in daily practice. And
right.
In terms of the LET calculated planning software. I think some centers in Japan are investigating
Yes.
for future clinical use,
Yes.
but not yet in the market.
Not. So, and what is your take on a MR simulator in the Proton facility? Do you think it has got a huge utility, or do you think the MR simulator is still not mature enough to be incorporated into a Proton center in terms of utility?
I think ML-based, you mean MR-based IGRT or?
No, MR simulator. Now,
Oh.
some of these MR simulator actually create synthetic CT scans, which can be used for radiation planning also. So do you think at the current stage, the MR simulators are mature enough to be introduced into a Proton facility? I mean, this will be useful for people who are planning to set up proton therapy facilities, and you are debating on whether you should be having the MR simulator and a dual energy CT simulator in your facility. So my question was actually based on those two queries. So if you have some experience, we could gain from your experience whether it is worth investing that money into these kind of equipment.
Unfortunately, I have no experience or no idea regarding
Right.
MRI.
Right. Maybe Jeffrey has a lot of experience with planning.
I was going to answer your question. So in fact, we have actually looked at this very first question. So we have just recently concluded our RFP for CT scanners. So we are going ahead to purchase two dual energy CT scanners. And the reason is for this more accurate characterization of the stopping power. We have also evaluated MR simulators, but I think at this point, our focus is to get dual energy CTs first rather than to do the MR. And I think the MR will really be beneficial if you have a MR Linac, and that will help with the workflow. So you plan on MR and then you can treat an image on the same thing with especially in children to avoid radiation dose. But I think the calibration of the stopping power curve is still quite early on, and we're not sure where it's going to move. And also, in fact, MR simulator is very much more expensive than the dual energy CT anyway. So I mean, that is our plan. To Dr. Kajana's question, I think that we have evaluated various ways of treating, and most people would treat CSI supine simply because you treat through the couch for bolus effect, and also because it's more stable. For prone, you have to worry about respiration, and usually that's not done. So in our center, what we're going to do will be posterior fields for the spinal. It can be wedge pair if you want to be more sparing, but also with the view of also having laterals for the brain. So most likely we will do pure protons for maximal sparing, although some centers have done mixed mode. Just like what Dr. Oshiro has said, where sparing in the brain is probably not much with protons because you're treating the entire brain. But if you're talking about things like, reduced volume or cavity or ventricle treatments, then of course protons will still be superior. And it's very hard to tell your patients who have come all this way for protons that you're going to only be giving half the treatment for protons.
Thank you all for interesting, excellent discussion, but I think it's about time to wrap up. So thank you all. And I'd like to invite Dr. Jolene Ye for Far-Off Treasure for closing remarks.
Okay, thank you, Mariko, and thanks to our colleagues from JASTRO to give me this honor to have closing remarks. So I think today's webinar is a very impressive for all of us, and the proton therapy is a very advanced technology in the radiotherapy field, and it can be the children, pediatric tumor patients should be is a very good candidate for proton therapy. And nowadays, we know that proton therapy is developed rapidly within our Faro country, especially for China. And nowadays, we have 3 proton therapy used, and within 2 or 3 years, we will have 15 proton therapy center will be used. So we are very hope to have much more chance to learn from our clinical, especially from the JASCO, and share your experience with us. So, and today's webinar is very helpful for us. So I'd like to thanks all of our speakers and panelists, and the Varian give us support, and especially we like to thank our colleagues from Indonesia Radiation Oncology Vigilant Association to give our technical support, and thanks all of you to join this webinar. Thank you.
Thank you so much. So we go for the photo.
Yeah, sure. I will give the instruction for photo session. Maybe everybody can open the video. Okay, please hold your position for 3 seconds while we are taking the photo. I will count in 3, 2, 1. Smile. Okay. One more time. 3, 2, 1. Smile. Okay. For the last one. 3, 2, 1. Okay. Thank you very much.
Thank you all for participating. I'm sorry that we couldn't go over all the questions. So we now close the session and the webinar.
Thank you very much. Hopefully we'll meet physically soon sometime.
Yes.
Yes, yes, yes.
Hopefully in like 1 year, hopefully.
Yes, yes, yes.
Thank you all.
So
It
take care.
was an excellent session. Thank you.
Bye-bye.
Thank you.
Bye-bye.
Everyone.
Bye-bye.
Bye-bye.
Bye. Thank you, Mariko.
Yeah, thank you. I used too much time, I guess. 20 minutes extension, sorry.